Thank you. Good evening, all our members of Maharashtra Ophthalmological Society and all members who are joining us from also across India from AIOS, especially all our young stars, our young ophthalmologists who are joining us today.
Thank
That
you.
too who are continuing
Good
with the
evening, all
residency
our
program. Maharashtra Ophthalmological Society and its scientific committee has been always involved in PG programs, and every month we have been curating two PG programs, and each month has been dedicated to one specialty. And we are happy to have the refractive surgery as a specialty of this month. The refractive surgery specialty is very special because I think very few postgraduates actually have full exposure to it during their residency program. And this has been the second webinar today for the postgraduates, and we are very happy to deliver it up to you for the sake of benefit of all our postgraduates. I'm sure even our comprehensive ophthalmologist will also benefit a lot from these webinars, which are full of pearls and also full of basics in refractive surgery. Today, we are going to be joined by our national faculty, Dr. Himanshu Matalia, and our MOS faculty, Dr. Vaishal Kenya. So from MOS, we welcome both of them. We are also going to be joined by the chief mentors of today, Dr. Mukesh Baryani and Dr. Yogesh Chauguloy. So from Team MOS, we welcome both of you as well. And today's session is going to be moderated by Dr. Neeraj Israni. And the whole PG programs are curated and they are coordinated very well by our very dynamic Dr. Sumit Lahane. So before we go further, I would like to now request our Honorable President, Dr. Santosh Agarwal, sir, who has been leading from the front, from the beginning uh, to this day. And now also we would like to announce that we are soon going to have the MOS Midterm Conference, the second edition of it on the 4th and 5th of May. This is going to be for the first time with the international UO session also, along with the Young Ophthalmologist competitive session as well. So over to Dr. Agarwal, sir, for his welcome address for today's webinar. Thank you.
Thank you, Vardhaman. Respected teachers, seniors, and my dear friends, postgraduate friends, very good evening to everyone. At the outset, I thank all the experts, panelists, faculties, teachers for sparing their valuable time for this PG teaching webinar. MOS always strive to lift our PGs and fellows and young ophthalmologists in terms of their practical training. I appeal all PGs to take part and attend such webinars to gain the knowledge and skill as much you can. We are fortunate enough to have respected teachers and stalwarts in this field on the same platform to discuss the very important cases in refractive surgery today. So please take out the notes and imbibe the tips and tricks from the discussion which we are going to have today. My best wishes to the PGs who are going to present the cases today. I also thank Dr. Vardhaman, Dr. Sumit, Aditi, and whole scientific committee team for taking immense efforts to curate this webinar. Thanks again to all. And today's my quote is success is never an accident, but a result of unyielding integrity, scientific excellence, smart hard work, and upgradation of knowledge. So I wish all the best to our PGs. Thank you very much.
Thank you so much, sir. And thank you for your words of wisdom every time. I'm sure it is going to enthuse a lot of excitement and a lot of inspiration in our young ophthalmologist brigade. So without further ado, I would like to now hand over the let's say moderation and the further handling of this webinar to Dr. Proceedings to Dr. Sumit Lane and also to Dr. Neeraj. Over to you, Sumit. Thank you.
Thank you, sir. Good evening, everyone. And thank you, MOS, Santosh sir, Atul sir, Vardhaman sir, Aditi ma'am for giving this platform to the PGs. We are reaching out PGs from all over the corners of Maharashtra, and they are very happy that they are getting this platform for presentation in front of all the mentors. Today we have our national panelist as Dr. Himanshu Matalia sir. Sir does not need any introduction. Sir is the Director of Refractive Services at Narayan Netralaya, Bangalore. He has trained number of PGs and fellow over the years, and since last 20 years. He's my mentor, Neeraj mentors, and Mukesh's mentor as well. So we don't have to say anything for him. So thank you so much for taking out time and being here. We have Dr. Vaishal Kenia sir here. Sir has over more than 27 years of experience in ophthalmology. He is the director of Landmark Hospital of Mumbai called as the Kenia Eye Hospital. Sir, for us, is like a current opinion in ophthalmology because, as far as I know, he is the most well read and most updated cataract and the refractive surgeon we have in India. Our mentors today is Dr. Mukesh Pariyani, sir. Sir is a cornea fellowship trained at Narayan Netralaya, and he's a consultant at HVD and also has his own clinic in Pune. Sir has a keen interest in refractive surgery and PG teaching. Thank you, Mukesh, sir, for being here. We have our another mentor is Dr. Yogesh Ogle, sir. Sir is an alumni of AFMC Pune. He has done his cornea fellowship from Arvind Eye Hospital, and he has keen interest in keratoconus. He is associated with the National Institute of Ophthalmology and also runs his own clinic in Pune. Thank you, Yogesh, sir, for being here. And to moderate the whole show, we have Dr. Neeraj Israni. Neeraj is again a cataract refractive surgeon from Narayan Netralaya. He practices in Navi Mumbai. He's very dynamic member of BOA, MOS, and Navi Mumbai Ophthalmic Society. He is innovator. He is one of us who has patent, and very less ophthalmologist or very few ophthalmologists have patent by his name. Neeraj has done it in very young age, and he's a very dear friend. Over to you, Neeraj, to get the show on. We'll start with Dr. Shriya Mashilkar. You can start the presentation. Neeraj, over to you.
Thank you, Sumit sir. Shreya, we can start your presentation, please.
Yes, sir. Good evening, everyone. I'm Dr. Shriya Mashilkar, a resident of final year in HVDSI Eye Hospital, Pune. I would like to thank MOS and my mentors for helping me put up this presentation today and giving me this platform. To start my case, a 22-year-old female resident of Pune, model by profession, came to the eye outpatient department to get rid of a spectacle number. On history, the patient has been using power glasses since school-going age. There is no history of contact lens use. There is no history of allergy or frequent rubbing of eyes. There is no history of pain, discharge, or redness in the past. There is no history of doubling of vision, and there is no history of keloids. On further past and personal history, there is no systemic history of diabetes or hypertension. There is no normal appetite, bowel, and bladder habits. There is no smoking or tobacco chewing history. Past medical history shows no surgeries and no medications that the patient is currently on. And there are no similar complaints in the past in the family. The systemic examination was normal. Ocular examination showed facial symmetry, which was present. Head posture was maintained. The forehead and eyebrows were normal. And the patient was orthophoric on Hirschberg test. On checking her glasses and doing a dilated refraction after putting cyclopentolate tropicamide plus and cyclopentolate again, we got a similar refraction. So we confirmed that the refraction was stable. On examination of the eyelids, there was no evidence of blepharitis or MGD. The conjunctiva and sclera were normal. The cornea was clear, and the tear film was normal as well. The intraocular pressure taken by Goldman's applanation tonometer was 12 millimeters of mercury at 11 a.m. The ocular movements in both the eyes was full and free, and the nasolacrimal passage were freely patent in both the eyes. The anterior chamber examination was normal in both the eyes. The iris color and pattern was normal in both the eyes. The pupil was singular, circular, regular, and 3 millimeters in mesopic light. Brisk and sustained reaction to direct and consensual light reflex was present in both the eyes, and the lenses were clear in both the eyes. And the fundus examination using 20D, a dilated fundus examination was done, and it was normal, and there were no treatable lesions in the periphery as well. So we went ahead with a planned surgery of both the eyes of wavefront optimized microkeratome assisted Lasik surgery performed under topical anesthesia, which went uneventful. The percentage tissue altered was 32.55 in the right eye and 32.70 in the left percentage. And the residual stromal tissue bed in the right eye was 378 and 370 in the left eye. On the follow-up visit, post-operative day 1, the uncorrected visual acuity in the right eye was 6.6, whereas in the left eye was 6.6 paths. But the flap was in situ, interface was clear, and the IOP was normal. So we continued topical medications, but the patient followed up again at post-op 2 months with complaints of persistent blurred vision in the left eye. So cycloplegic refraction was done, and it showed an error of minus 1.25 cylinder diopters in the at 25 degrees in the left eye, which was correcting to 6.6. So the plan of action after this was a topo-guided LASIK enhancement. So our provisional diagnosis was astigmatism post-LASIK surgery in the right eye, whereas the left eye was emetropic. So I've included pentacam ahead, but as far as the PG point is concerned, I was asked to explain till the case here.
You can show the topography as well, so the discussion would be easier.
Yes, sir. So the preoperative pentacam values have been shown here. The keratometric values are within normal range. The Q value is also normal, a prolate cornea. There is no, on the quad map, the actual map doesn't show any asymmetric bow tie or skewing of the radial axis. The thickness is within normal range with 559 at the pupillary center. And the elevation maps are also within normal range. So the post-operative 2 months map shows a slightly decentered ablation. And after that, the residual, as in the pachymetry after the post-op was normal. And hence we could plan a relifting of the LASIK flap and ablation again using topo-guided LASIK. So a map plan was created using the Atlas Zeiss, which shows that this is the decentered ablation. And we went ahead with the plan where the red hot area shows where the laser would be fired again to correct the decentered ablation in the past. And again, after post-op, the uncorrected vision was 6.6 and the quad map is within normal range. So this is the comparison of the post-LASIK day 1, and this is after this enhancement, how the ablation is centered again.
Excellent presentation, Shreya. I think for a postgraduate, you have presented it very well. And I think to take this forward, now we would request Dr. Yogesh sir to just highlight what better she could have done in the presentation, and if probably you have some questions for her.
Excellent presentation, Dr. Shreya. I think the provisional diagnosis you have to change. You mentioned that right eye having astigmatism, post-LASIK astigmatism, but actually it is in the left eye. Right?
Yes, sir. Sorry, I changed.
Yeah. So, again, I feel when was the topographic or LASIK preoperative pre-op workup was done? It was done on the same day or
So no, prior to 7 days prior to the surgery.
7 days prior to the surgery, right? Okay, fine. That you have to mention because you cannot do the preoperative LASIK workup on the same day of the general examination of the eye, right? So, wonderful case. We just go with the basic questions like what are the types of refractive surgery you know? You can just elaborate a few of them.
So I can mention them under 3 headings.
Right.
The cornea-based refractive surgeries and lens-based, and also bioptics and trioptics, which are combined. In cornea-based surgeries, there is PRK, there is LASIK, there is epi-LASIK, there is LASIK, and smile surgeries. Whereas in lens-based, we have a phakic IOL, and we have a refractive lens exchange surgery. And
so smile surgery is nothing but lenticular extraction. Now there are different companies are come up with the lenticle extraction technique. So SMILE is a patented technique to one of the platform. So you can elaborate, like, yeah, small incisional lenticle extraction technique. You can describe like that. Okay. And what are the contraindications do you consider prior to proceed for the LASIK surgery?
So an unstable refraction, an underage patient, minimum criteria for LASIK being more than 18 years. Then a dry eye disease patient having ongoing blepharitis or meibomian gland disorders, patient having uncontrolled diabetic or active connective tissue disorders. A history of keloid is a relative contraindication in a patient for LASIK at least. Any contact sports, or if the patient is planning to go into military, that would be a contraindication for a flap-based refractive surgery.
Also, any past history of herpetic infections, you should avoid doing.
Yes. Any
LBC.
other ocular comorbidities such as uveitis, glaucoma, or vision-deterring retinal pathologies are a contraindication to go ahead with the surgery.
Even presence of plaqueta, you should consider, yeah.
Dystrophies.
Dystrophies.
And,
anything in the cornea?
Corneal ectasia, sir. Allergic conditions, uncontrolled allergic conditions. And
so nightmare for any refractive surgery, a surgeon would be missing out on ectasia, right? So that's something which should be your first thing where you would be practically or theoretically you should be ruling out. So
yes.
It should be right there in the list, your corneal ectasia, whether it's keratoconus or anything else.
Okay, good. What are the normal values of keratometry and pachymetry?
So normal range of keratometry is between 40 to 46 diopters. More than 47.2 is considered a suspicious range of steeper corneas. And pachymetry is central pachymetry is usually 540 to 550 microns. So
you can consider like a standard deviation having 530 plus minus 20 microns in Indian population. And how do you calculate percentage tissue ablation, or how much of RST, residual stromal thickness, do you expect post LASIK?
So the percentage tissue ablation is calculated by ablation depth is first calculated using Mueller-Lens formula, which is 1/3 of the optic zone squared into the diopters that we're correcting in the refractive error in diopters that we're correcting. That plus the flap thickness will be subtracted from the central corneal thickness to get the residual stromal bed thickness. And percentage of tissue ablation is flap thickness plus the tissue ablated divided by the central corneal thickness.
Tissue ablation depth divided by the
central corneal.
Central corneal pachymetry. What is the PTA ablation percentage? Do you? What is the cutoff value for the PTA?
More than 40%, sir.
Okay, up to 40 or more than 40, you should not consider laser visual friction. And what is the cutoff value for the RST?
More than 250 microns should be.
So most of the surgeon prefers 300 microns, but few of them go till 280 or 250 also.
Yes.
Dr. Himanshu can elaborate more.
I think you're absolutely right. Practically speaking, so as postgraduate, you should be talking whatever is there in your books here, because you're not going to contest that thing with your argument, with your examiner there. Practically speaking, we know that it's not just one particular value, which is the make and break kind of value. That the entire case, what you decide, it's based on that. If that means that somebody who will take 251 as LASIK possible, 249 as LASIK not possible. Well, it does not happen in real life like that. But of course, for your exam, whatever you have to speak, you should be talking about that. Most of the time, ectasia are such multifactorial that we cannot decide about the etiological factor or responsibility of one particular parameter for ectasia. I mean, we all would have, those who are older like me, would have done LASIK for much higher refractive error because there was no concept of such a residual bed in olden times. And still, the incidence of ectasia was not so high. So, in spite of treating minus 14 power or 15, not all of them were actually ectatic. Right? So, incidence of ectasia being such low, it's very difficult to study that kind of thing because you cannot have prospective trial of such things. And being multifactorial, sometimes it becomes very difficult to study such kind of thing. But thankfully for us, that also means that sometimes some slippage may not actually be as bad and you may be on the right side, but same time, it also means that sometimes when you do everything right, you still may end up having ectasia. So yeah, that's something which we all know. Not everybody who is suitable for, not everybody who asks for surgery, LASIK surgery, is suitable for laser refractive or any refractive surgery. Hence, your pre-op evaluation is very important. One thing which I felt we can just include in pre-op evaluation is axial length measurement, and extremely important, which would help us in deciding about maybe future cases. We'll possibly, if we have something, we will talk about that later on.
And what is the importance of asking contact lens history or having keloid deformities in the body?
So contact lens, if the patient is using a soft contact lens, we would ask them to discontinue using them for at least 1 to 2 weeks prior to taking the topographic measurements. And if using a rigid contact lens, we would ask them to discontinue at least
1 week or 2 weeks. Because if you are sitting on a chair and you get a patient, whether you ask patient to discontinue for 1 week or 2 weeks.
From the patient's point of view, 1 week would be suitable because
you are the surgeon. You decide what. So your answer is right for the exam purpose, because some of them may need a couple of weeks, 2 to 3 weeks time. Some of them may be okay with 1 week time. So people who are okay with 1 week time are spherical contact lens users and not having any features. Okay, so how do you know if somebody has any effect on the cornea, those contact lens wearer?
So the topo map will show a warped, as in there'll be flattening on the periphery and
not periphery, wherever the contact lens sits.
Yes.
So that's called contact lens warpage.
Yes.
Right. Contact lens warpage is something which is where you see the change on the anterior surface of cornea. It does not reflect into the posterior surface, and that's contact lens warpage. If you have even spherical contact lens and if they have sign of contact lens warpage, you surely would want to stop contact lens for much longer time. Otherwise, you can safely discontinue for a week time. If somebody is wearing toric lenses, where your corneal bearing will be a little different, the contact lens would sit on those areas and press on that part of the cornea more, and you would want to discontinue it for a couple of weeks, 2 to 3 weeks time. RGPs, because they touch on the cornea, though RGPs are not very commonly used now, but they have bearing on the cornea mid-peripheral touch. Hence, they also need to be discontinued for 3 weeks time.
Yes, sir.
Perfect. And lastly, can you tell us the topographic findings of keratoconus?
In keratoconus, the pod map and axial curvature will show keratometric value more than 47 or 48 diopters, should be steepening. There will be asymmetric bow tie appearance and skewing of the axis of more than 22 degrees. In pachymetry, there will be thinning, less than 470 in a normal looking topo and less than 500 microns in an abnormal looking topographic finding should be suspicious. And superior inferior steepening of more than 1.4 diopters is also suspicious. and an anterior elevation of more than 12 microns and a posterior elevation of more than 18 microns is suspect for corneal ectasia and keratoconus.
Okay. Dr. Vaishal, do you want to add something on this point? Yeah, you're muted actually, sir. Sorry.
One second.
Yeah.
So, see, corneal ectasia, the most important thing is that a tomography has to be done. That is more important. Topography sometimes can miss because as you know, the keratoconus is first detected on the back surface or the posterior. So a topography can miss sometimes if the keratoconus is subclinical. So it's very, very important that whenever you are doing a refractive surgery screening, it has to be done on a tomographer. Though changes in keratoconus or progression keratoconus can be more detected better by a topographer. But any subclinical keratoconus has to be detected on a tomographer. So that is a very, very important thing. You cannot just use an ultrasound pachymetry for doing a pachymetry. You need to do OCT based pachymetry. And one more important tool which I am using in my refractive practice for all my cases is epithelial mapping. Epithelial mapping is very, very important to understand if any steepening on the surface is there on a topography, where it is coming from. Is it coming from the epithelium, or is it a thickened epithelium, or is it coming from the stroma? Because keratoconus is a stromal disease where there is thinning of the stroma. Now, there would be certain keratoconus where there is thinning first and curvature changes occurring later. There are keratoconus where first curvature changes occur and pachymetric changes. So there is no one rule for anything, but one thing is there, that the keratoconus is first seen on the back surface. So it's very, very imperative to see about do a tomography, and on an epithelial mapping, you get a characteristic donut sign. Means the epithelium masks the keratoconus, though it is seen on both the surface, on the anterior as well as the posterior surface, but on the front surface, the epithelium masks the keratoconus. And this you can see it beautifully on the epithelial mapping as a donut sign. So I would definitely, if you have the facility of an epithelial mapping, this should be a part of refractive surgery screening.
Dr. Vaishal sir and Dr. Himanshu sir, I would just like to ask you from the aspect of a young refractive surgeon, if you have a case like this, how would you counsel the patient for a redo or enhancement? What is the exact counseling that goes in, and what are the points that you need to tell the patient in such a case?
Shall you want to go ahead?
Hey, you can say first. No problem.
So basically, Neeraj, it's not very common to have decentered ablation nowadays. So thankfully, these are not common cases. It's not something a mistake of a surgeon, because LASIK surgery, the human intervention is very less. So we really don't need to take blame as a surgeon on us for sure. So I would explain to the patient that this is the condition, this is what the. So also one thing, Shreya, I mean practical point, Shreya as well as others. Post refractive surgery, whenever you want to show topo, the better map is not the axial curvature map, but it's tangential map. That shows you much more precisely whether the ablation is centered or something. Sagittal map has a fallacious nature of having a notch inside, because the entire curvature is pinned towards the center on the vertex, and from there it's making the hemimeridians, and hence you would have fallacious shape seen there. So it's always better to show the tangential map. So even if you want to see whether it's centered ablation or not, you always look at the tangential map, whether you have elevation based topographer or whether you have placidus based topographer. Your tangential map is the one which you should see before you decide about whether there is any decentered ablation or not. So once you see the decentered ablation, and when it has reduced the best corrected vision, when it is induced some kind of astigmatism, and which is obviously seen on day one, there's no other way out, and you will have to treat this patient. I would show the patient the topography picture, and I would tell the patient that though it's extremely rare scenario, I'm not trying to blame you that you did not fix it, but let's go through the fixation procedure one more time. So for you to understand that when we go for an enhancement or something or retoucher, you would know where to fix it. And that sort of conveys to them that, you know what, I mean, you possibly did not fix it very well that time. And you need to be a little careful about the fixation next time. If the flap was centered and only ablation was decentered, we are relatively okay. Flap itself was decentered, then lifting that flap would not be the best idea. If the ablation was decentered, I would surely tell patient that, you know what, we will be using your corneal topography, and using that we would try to correct this thing. But sometime in such kind of scenario, when we try to correct it, it may have a different outcome in terms of sphere. So your spherical outcome can be a little different. But my plan is, I may plan 2 steps. In first step, I would recenter everything. And if required in second step, I would try to do the touch up for your spherical outcome. Having said that, we know that most of the time that would be 1 step would be enough. And patient would be actually happy with you delivering in only 1 step. But if at all you need, patient still would be prepared that you can go ahead with the second step, and you can do and way from the optimize touch up also for the second step, which is absolutely fine.
The only thing which I would like to add is be very honest and transparent with your patient. It's very, very, very important. And as Himanshu said, tell about the 2 steps. Sometimes you may require a touch up, and then if you have not spoken about it, then it's a very bad, tough situation. So sometimes the question occurs that when to do the flap lift. Classically, the books have described 6 weeks or 8 weeks wait, but in such cases, post LASIK, I have lifted as early as the 3rd day. Why? Because in a private practice, the patient is quite, very apprehensive, and the relatives, everyone is in a panic mode. And we know that lifting it as early as the 3rd day would also not matter much. And treating it away, you are treating the cause and addressing the problem, and that would solve their anxiety completely. So waiting for 6 weeks or 8 weeks, as classically described, can be changed, and you may not go as per the textbook and do it early.
Totally early. I totally agree. So this is, see, the logic of 6 week was that whatever the refraction which you get. So basically, it's not just 6 week. It's like you have stable topography and stable refraction, which is done 6 weeks apart. Whichever is later. If refraction is not stable at 6 week, you wait for another 6 week. That was the idea of the refractive error being stable and corneal healing to occur. Now here we know the culprit is decentered ablation. So there is no need for us to wait for, as Vaishal said, you can take as early as possible whenever you recognize, and you surely can take it up, and you rather should take up little early.
Since both of you are such volume surgeons, just wanted to ask the number of cases that you have done redo or enhancements. What is the chances of epithelial ingrowths that you have seen in such cases? Or how many percentage of your patients have developed ingrowth? Will that also be told to the patient preoperatively before doing a re-enhancement?
Epithelial ingrowth typically, Neeraj, is seen very rarely. If your basically this occurs when your LASIK blades have been reused. When the LASIK flap handling, the edge is not opposed properly, or the culprit is the flap management. If your flap management is proper, epithelial ingrowth occurrence is very, very rare, unless it's a hyperopic treatment, which usually in our subset of patients, it's mostly myopic treatment. So in hyperopic treatments, you do get, because of the shape of the ablation which has occurred, you can get epithelial ingrowth. But all epithelial ingrowths, I would say, may not be lifted and treated. That's the other thing. You may see an epithelial nest just at the edge, and you can observe it, and it may not grow for long. And sometimes you can use the YAG laser to YAG it up, and if it's on the periphery. So epithelial ingrowth is basically because of flap management, and a proper flap management, you may not get this thing. And if you are doing a retreatment, one more point I would like to say is put a bandage contact lens over the flap, so that helps in opposition of the flap margins.
Neeraj, can I add one point?
Yeah, please go.
Yeah, only thing is that if the patient is coming in the post-operative period with any kind of refractive error, so you see at 1 week the patient is not very happy, you see a refractive error, we have to do a full cycloplegic refraction, because accommodation spasm is very, very common. And many times we see these patients are they are going to spasm, and the moment you put a cycloplegic prop, the myopia disappears. So for postgraduates, it's very important when they see the post-op, they see the auto-ref of -1.25, -1, they have to rule out two things. One is the pseudomyopia, and obviously is a steroid responder, because both of them are very common in these patients, and not to appear very this thing, oh, it's refractive error, residual refractive error. You have to appear very calm, quiet, and then follow the process.
Okay, so if we are not having any case of post laser refractive surgery refractive error, then we can discuss that here. Do we have any cases on that today?
We have our next case, which is Phakic IOL. So I think.
Okay, so in that case, as a surgeon, we should remember. Oh, please, sir, please.
Sorry to interrupt, but maybe just. What should be the strategy in a case of an incomplete flap? See, most of the times the flap is not through and through complete. So what the surgeon should what ideally he should go through the process? What is the thing to be done in such cases?
Okay, so basically it depends on when are you detecting incomplete flap. Now, whether it was a femtoLASIK, whether it was an MK LASIK. If you have MK LASIK, there is no way you're going to do anything but just abandon the surgery, wait for it to heal. As we discussed earlier, stable refractive error, stable topography, done 6 weeks apart, 2 of them, whichever is later, and then only you're going to touch up on that thing. Second time, when you are making another flap, please remember that it may be related to either your instrument factor, which is your microkeratome. It may be related to the curvature of the patient. It may be related to your vacuum. Now, you may not be actually changing your instrument. You may change your vacuum ring size and those things. But having said that, there are likelihood that you may end up in similar situation. It's not worth it. So you would rather do a surface treatment than trying to be a hero and trying to make another flap there. So no, trying to lift the flap is a great idea. If you're doing a femto LASIK there, based on where you have got vacuum loss, now, if it's in the beginning, you can actually take up same time, and you can go ahead without making a pocket or without making a channel, and you can go ahead with the same ablation, and you can still go ahead and do it. If it is there, which is in the visual access area, I would not be very keen to go ahead and continue that part, because there can be a step defect, which can be a microscopic step defect. But if it's in visual access area, you may compromise the quality of vision there. So you might want to defer this case for another day, and you surely can plan for a redo, which is again femto flap. It's absolutely fine. If it is something which is beyond the visual axis area, then again you can consider going ahead and making, because that step defect is not going to come in the visual axis. So if it is MK, it's a little different. If it is femto, it's a little different.
I just brought it to notice because of one point we had such case, and the reason was found is to be it's a pseudo vacuum buildup. So there was a block in the ring, and we thought the vacuum is achieved and the microkeratome will go through and through, but it will stop. It had a vacuum loss, and then we had an incomplete flap. So the reason I found it that the tube was, the ring was blocked. So that's why it gives an pseudo vacuum achievement level.
True, sir.
Thank you. Thank you.
So coming to the refractive error post LASIK surgery, as a surgeon, we should remember from our sleep also, somebody wakes you up, you should know there are 6 causes of refractive error post LASIK surgery. First, deliberate or non-deliberate undercorrection. So whether deliberately you plan to undercorrect or somebody else by mistake has gone ahead and treated which was not accurate, these cases will show refractive error on day 1. They would have all such kind of blurred vision and all those things immediate post-op. If it's not your case, you can ask for primary surgeon that did you deliberately undercorrect, or go and check the settings what the entry was done. Second is spasm of accommodation. Typically does not occur on day 1. So day 1 vision will be very good. Typically occurs 1 week, 1 month, whenever they start working closely on the computer, mobile and those things. Younger patient can have spasm of accommodation. Typically shows as Mukesh was saying, pseudomyopia. Hence, any refractive error post LASIK surgery, you must do cycloplegic refraction. There's absolutely no choice. Every case, any refractive error post LASIK, you must do a cycloplegic refraction. Third is myopic regression, which is change in the keratometric value, which is a long term, which we are talking about, more theoretical, does not actually occur practically. Its change in the K values or curvature of cornea can be detected on your topography. So you need a baseline topography. That's where your 1 month topography can be useful, and which you can compare later on. Can take months together, years together, and for which also it's like probably in a year at 0.06 diopter change can be the curvature change, which is actually theoretically, practically does not exist. The fourth thing is progression of myopia, which is the commonest cause of refractive error. Again, day 1 month would not be abnormal. You may have at 6 months, 1 year progression. That's the reason you must do an excellent measurement operatively, so that you can compare and do not call every refractive error as a regression. It would be a patient factor, which is progression, which is not your mistake. So always measure axial length. Fifth, it can be cataract. Again, takes years together. We know we can examine it on slit lamp or your abrometry and those things. And sixth, which possibly all of us would be scared, would be post-LASIK ectasia. Does not occur immediately, very rare. Any changes we see on posterior elevation has to be post-LASIK ectasia. So always remember, there are 6 causes of refractive error post-LASIK surgery. As a surgeon, you should know, and when a patient walks in, you should know where to possibly point a finger at.
The other thing is, now we know that there is a residual refractive error. When should we treat? That is very, very important. Immediately, if you treat, again, is a problem. You should, like, if there is, as Himanshu said, there is myopia progression. Is the progression continuing or not? So we have to see where, if the patient over a period of 6 months or sometimes 1 year, whether the progression is occurring or not. Has the progression halted or not? Because if you treat before and again the progression occurs, then you're not going to treat it the third time. So it's very, very important that we not only see the residual error, but also wait. And then see the stabilization and then treat the refractive error.
Thank you so much, Kenya sir. Due to paucity of time, we will have to move ahead with the next case, which is again very interesting. I would request Tanya, who is a postgraduate from NIO Pune, to please start her next case.
Yes, sir. I'll be sharing my screen now.
Tanya is presenting a case on Phakic IOL.
Good evening, everyone. So we'll be discussing this case. A 23-year-old gentleman presented to us for getting rid of his glasses. He has been using thick lenses for around 15 years now, and the glasses have been, his refraction has been stable for more than 3 years. He has a history of both eyes barrage laser, which was done 8 years ago, and there are no systemic comorbidities, past surgeries, ocular trauma, or any chronic medication that he's been using. On examination, so he's been using glasses of minus 15.25 sphere, minus 3.25 cylinder at 15-degree axis, and minus 15.25 sphere. So this was his refraction, and he was able to read 6.9 and 6.18 in right and left eye. We had given him a refraction new trial, and there was no doubling, and duochrome was balanced where he was seeing red and green equally. So his refraction came out to be minus 16 sphere in right eye, with roughly minus 3.25 cylinder in both eyes. And he was able to read minus 6.9 and 6.12 respectively. Anterior segment examination was within normal limit with normal intraocular pressure. Posterior segment examination showed temporal crescent, lattice degeneration, and laser scars, which was noticed in both the eyes. So my diagnosis would be both eyes have myopia with myopic retinal degenerative changes and laser scars. We had proceeded with workup, and we had done his corneal topography where the tangential anterior map showed symmetric bow tie. The important parameters here were the horizontal visible iris diameter, or the white to white, the anterior chamber depth, the simulated keratometry values, and the pachymetry values, similar in the left eye. We had also taken readings from his ocular biometry, where we had measured his axial length, pachymetry, anterior chamber depth, and white to white diameter. His OCT showed thinned and stretched out retina in both the eyes, and his specular showed normal cell count with mild polymegathism. So since he was interested in refractive vision correction and had high minus refractive error along with good anterior chamber depth, we had suggested toric phakic lens for the patient, and we had sent all these parameters to the company. We had also measured his white to white diameter using the manual calipers, the IOL and series. So 3 measurements were taken to determine the size of the phakic lens. So after the company, we had sent it to them, they had given us these sheets, and the final refraction was the lens power was in the right eye, it was minus 19 sphere with plus 2.5 cylinder at 100-degree axis, and minus 19.5 sphere with plus 2.5 at 70-degree axis. So the implantation of both the lens was done around 4 days apart, and post-operatively, this was day 14. We had taken, I do not have it for the left eye, this is the right eye wall. It was 361 done on the anterior segment OCT, and post-operative vision was 6.9, 6/9 near vision N6 with good vault and normal intraocular pressure. Thank you.
Thank you, Tanya. I think you should be grateful to your institute to give you a case of Phakic IOL, because as postgraduates, we never saw a Phakic IOL. Quickly, we will go to Dr. Mukesh Paryani, sir, who has also been my teacher and taught me a lot about refractive surgery. I think Dr. Mukesh Paryani will ask you a few questions related to this case.
Yes.
And a very well presented case, I must say. We will start with some very few questions, and I would like to start with you mentioned the anterior chamber depth of the patient. What is the normal anterior chamber depth, and what is the cutoff for the normal anterior chamber depth when we are looking at the phakic IOL implants?
So the normal range is from 2.5 to 3.75 or 3 to 4 mm, we can say. And it would be adequate if it's more than 3 mm, so as to maintain a good wall post-operatively.
And for hyperopic patients, if at all somebody plans for phakic IOL, what is the cutoff for the anterior chamber depths? Same. It's same.
Okay.
Okay, so for myopia, it is, you said correctly, more than 2.8. Preferable is more than 3, but anything more than 2.8 is correct. And for hyperopia, it is +3. And I think you showed a vault size of around 831.
So 631, it got pixelated.
Okay, no problem. And what is the normal vault size that you think should be? What's the
So
range?
from 250 to 750 micrometers usually, which is around half to 1.5% of the corneal thickness, if we have to say.
What is so if you have a high vault or a low vault, what to be done in those situations?
So usually
What
a
is the
high vault
usually called? Yes, how many microns more than how many microns you will call as a high vault?
So high vault is when the distance is more than 750 micrometer and the iris is touching the angle and there's angle crowding. Along with that, there could be pigment dispersion or iris chaffing. When it's a lower vault, a very low vault, then the ICL could touch the crystalline lens and can cause cataract formation. So this means that the size of the ICL that we've taken is undersized or oversized.
Very nice. And just last question, what is the minimum cylindrical cutoff where you like to go for a toric lens or you will stick to a non-toric lens?
So usually 0.75 is the lower limit, 0.75.
Yeah. Otherwise, the case, you have presented your case very well. One last question, what are the complications of the ICL surgery in brief, if you can tell me?
So apart from the high and low wall complication, there could be a IOP spike or there could be rotation of the toric lens, the axis that we've not dialed it to the required, which was required.
Okay, anything else?
So there could also be pupillary block glaucoma, although these lenses have the central hole, but it could happen that it has blocked because of inflammation. There's a membrane formed in that way. Secondary glaucoma, meaning, yes, sir.
So usually when you answer in the exam, so you have to divide the complications into early complications or later complications. When you divide the complication, the process becomes very easy and you don't miss anything. Like you don't have to jump from the cataract part directly to the glaucoma part. And it comes in a really good phasic manner. So immediate post-operative period, the later post-operative period, what are the complications? And that's how you're going to build up an answer when you say, and it sounds more confident rather than jumping from this thing without the time frame.
Yes.
Great.
I just wanted to add one thing, that if a gonioscopy would have been added in the examination would have been good, because usually more than gonioscopy angle more than 30 degrees is preferable for an posterior phakic implant.
Yes.
So gonioscopy is very imperative in whenever you are presenting for a phakic lens.
Right. Noted.
I have one question for both the panelists, Dr. Himanshu and Dr. Vaishal sir. So as long as surgical tips, because it's a postgraduate training also, so I'm sure they've seen a lot of surgeries. So I have 3 points of surgical tips. One is which choice of visco do you prefer? Second is do you use pilocarpine? Or also one more question which I want to ask is in case of a non-dilating pupil, how do you tackle phakic IOLs? So his first question was, which type of visco do you prefer in these phakic IOL surgeries?
Vaishal, you want to go ahead?
Okay, fine. So viscoelastically, a cohesive viscoelastic would be the best, because at one go, when you want to remove it, it can come out. By using a dispersive, it is more, it's very difficult to remove. And behind the lens, whatever remains, it sometimes coats and forms a layer. So preferably a cohesive viscoelastic is the choice to use for a phakic IOL. I have been lately implanting phakic IOLs without using a viscoelastic, but that is after a certain, becoming a proficient and then using it. And we have been checking the endothelial cell counts pre and post, and there is not much difference. So, but for a beginner, it's always a cohesive viscoelastic to be used. That would be a better viscoelastic.
So basically, it's absolutely right. The thing is, again, it's a choice. By default, when you have to speak an exam, it may be dispersive viscoelastic, because that's what your company would be telling you to use. The idea earlier was that we were not sure about the interaction, tissue interaction of a cohesive viscoelastic with the anterior capsule, and we were a little scared about that. Hence, the companies told us to use dispersive viscoelastic, and that's still by default, it is dispersive viscoelastic. As Dr. Vaishal said, the issue is that it may not come out completely. Hence, your wash has to be thorough. You have to make sure that you wash behind the lens also. However, because the dispersive viscoelastic is easier to take out, if you spend little time, I'm sure you would be able to take it out. Disadvantage is that the central hole is not meant to accommodate viscoelastic. It's only for the aqueous. So even if you have left behind some amount of dispersive viscoelastic, it can block that, and you can have the raised intraocular pressure post-operatively. So a thorough wash is absolutely mandatory. Cohesive viscoelastic can be used, and it's easy to remove. However, we have to remember, if we do not remove completely, there can be a large blob of cohesive viscoelastic which can be behind, and you may not have too much choice but to possibly remove it and take up the patient. So that's one thing. Hydro insertion is third way, which does not lead to this kind of problem. As Dr. Vaishal said, can have little learning curve, but it's not as bad. So all three possible, should know what to expect from what.
So what is a post-op regime that you follow for such phakic IOL patients?
I would say answer can be different. Scientifically, answer can be different. Practically, I don't keep my protocols so too different for my staff to get confused. I do use steroid. I do use, steroid antibiotic combination, lubricants, and I'm quite okay with that. Anti-inflammatory, yes. But again, there's nothing scientific about it. It's more of so basically you are doing an intraocular surgery. Basically, your lens is in vicinity of iris as well as ciliary body. So just be aware of that. Whatever you want to do for such kind of cases, they cannot be right and wrong here. I think it's fine.
It's same as cataract protocols, basically.
Yeah, true. Yeah. I seriously don't like my protocols, too many different protocols for my staff to get confused, from my nursing staff, my fellows, everybody. So,
what is your experience with hyperopic phakic implants, and also especially these patients, with a smaller pupil or a non-dilated pupil?
So taking up, Neeraj, your first question of the smaller pupil. Now, it's very, very important to remember that good surgeons are good your clinical operatively, and then do juggling there and do things there is not something which is absolutely ethical. So I would surely want to see that what is maximum dilatation I'm getting. Now, if I'm not getting maximum dilatation, which is adequate enough for me to place a sulcus fitted lens inside, I won't mind giving it a slip, and I would say possibly not doing the surgery is also fine. Anything where you have a phakic eye, where you have a shallow anterior chamber, where you try to do any thing, stretching or anything, you can end up in lens touch, you can end up in endothelial touch. You may get, ideally speaking, for students when they're talking about such kind of thing for newcomers, I don't think it's a smart idea. You may want to leave one case or two cases, and these kind of cases can be extremely rare. I mean, you may want to just not operate in one case and then possibly suffer in more number of follow-up reviews with the same person. Talking about hyperopia, hyperopic phakic IOLs are not very common because one, it's very difficult to get a deep anterior chamber with high hyperopia and still suitable for phakic IOL. Also, along with this thing, I would be mindful about the curvature tomography or the curvature topography of, I'm sorry, the iris topography. That means the pattern of iris, whether it's a concave pattern or whether it's concave, convex hyperopes, they have convex configuration, and the iris, you may have central anterior chamber depth, which may be quite okay, but the periphery, as Vaishal was saying, can have a quite narrow angle and may not be the most suitable for thing. These cases do require these lenses, and you may want to reevaluate after peripheral irectomy, but not very common.
I'll just add to it that if we do a UBM in such cases, because see, there is a white to white and sulcus to sulcus doesn't have a linear relationship. So in hyperopic cases, sometimes it may be surprising that the sulcus to sulcus is smaller than the white to white, and whatever the ICL sizing calculator may give you a size may be oversized for, and these are small anterior chamber eyes or small eyes, and where a high volt can precipitate a pupillary block. So you have to it's very, very imperative if you can do a UBM and do a sulcus to sulcus in such cases. It can help you in sizing. And about small pupil, if it's very small in the range of 5 millimeters or 6 millimeters, I'm sure it'll be very difficult for anyone to implant an ICL, and the manipulations which go in, and by traumatizing the anterior capsule, it's not worth doing it. I totally agree with Himanshu. But when the pupil has slightly come down, say around 8 millimeters or 9 millimeters, with the the iris repositor, the applicator, you can tuck the haptic below the iris and go ahead and do it. So, but you have to be very careful doing it. In such cases, you can go ahead when the pupil is around 8 millimeters, 9 millimeters, you can. And about pilocarpine, you should avoid intracameral pilocarpine at the end of any ICL because it will exacerbate a lens touch. So you should avoid using intracameral pilocarpine, and plus it is pro-inflammatory.
So it basically leads to ciliary body, anterior rotation of ciliary body, and hence you will have shallow AC, and your vault will be totally skewed, and you would be scared, and you'll be shitting bricks your eyes back. So yeah, we do avoid that.
Thank you, Dr. Himanshu sir and Dr. Vaishal sir. If anybody has any other questions, I think Dr. Sumit sir, if anybody has questions, we can answer, or else we can go ahead with the last case presentation.
Yeah. Present your cases, those case scenarios.
So I would just like to quickly, because of, is my screen visible?
Yeah.
So I have two quick cases which are very interesting. Dr. Kenya sir is common in this case because this is something that we discussed a lot. So I've named it new software, old problem. This is a game changer in refractive surgery. So we all know that refractive surgery is nothing but hunt for at the risk corneas, and like sir said, a topography gives you the whole picture, but a tomography actually is what we need to find out if there is subclinical KC or KC suspect. And so this is a very interesting case. He was one of my childhood friends who came down from the US, and I did a complete refraction. I do a cyclopentolate refraction for all my cases preoperatively, and as you can see, the refraction is not too high. It's minus 2.25 and minus 1.75 in both the eyes cylinder. And this is a topography. You can see it's a very fairly simple, normal symmetric bow tie with a normal anterior elevation, no posterior elevation. 482 to certain extent is slightly less, but on calculating the RST and PTA, I thought the patient is good to go ahead. The Bellin-Ambrosio map also had a slight borderline, but then still I thought that the posterior elevation is not showing any changes. Similarly, the left eye also, you can see a normal symmetric bow tie with hardly any changes, 481 pachymetry, and Bellin again shows a slight borderline value. So obviously we have three options: PRK, Lasik, and Smile, and I chose the but obvious PRK and I told him that we would go ahead with the PRK tomorrow. And strangely, this friend of mine then visited Dr. Vaishal Kenya also, and Kenya sir obviously has all the gadgets. So he did this epithelium mapping which he was talking about. And as you can see over here, epithelium mapping also to a certain extent looks pretty much normal to me. I don't see any change in the epithelial mapping. Sir has access to Corvus. So I think sir, I don't know where the Corvus, but the Corvus showed a high CBI and TBI in this case. And sir then called me and spoke to me and discussed about this new software that is Accusumix, which is also, I think, used in Narayan Netralaya. And so what Accusumix does is that it is the first finite element simulation and artificial intelligence used software, which basically gives us a risk estimation for ectasia. So what it does is it basically takes in the data from the tomographer Corvus, the epithelium maps, and it predicts a ectasia preoperatively for the patient. So to explain this report, it takes around 1 full day, and thanks to Dr. Kenya sir, he could actually run it for the patient that I had referred to him. And as you see, the normal corneal stiffness should be something which is more than 102. So say around 102 plus 120, 130. But if you see over here, the preoperative corneal stiffness is itself quite less. It is around 67 over here. And in the left eye also, it is 66.51. So after a lot of discussion, this, according to the Accusumix software, it said that the patient is at a high risk of ectasia. And, keeping this in mind and sir's experience, I did not perform a surgery for my patient. Now, the thing is that my question over here is that, is this software a boon or a bane? Are we actually going to keep rejecting cases on basis of this software, which is obviously very helpful? Quickly, I'll go to my next case also, then we can discuss both the cases. So this is a 22-year-old female who came to me, and she had a 14-hour, more than 14-hour screen time. And this was an old case. So this is a case just post-COVID. And the patient had a refractive error of 2.25 in the right eye with a SIL of 1.5. And the uncorrected vision was 624, best corrected was 6/6. The left eye, I thought I would best leave it alone because there is hardly any refractive error. What I did was that everything was normal in this patient apart from the fact that she gave a history of acne and she was on a isotretinoin supplement which was around 10 mg per day. So I did some research and I saw that only in high doses isotretinoin has led to is a contraindication for refractive surgery. As you can see, the maps are also quite normal. The posterior elevation is normal. There is no anterior elevation, and it looks like a fairly normal map to me. This was a serious topographer in this case. So I counseled the patient and then gave three options again to the patient. Since the patient was wanted a very safe procedure, I went ahead and did a trans PRK for this patient. Coming to the MMC, the surgery was uneventful. MMC for 35 seconds is what I use. That is 10 seconds per diopter. And I use my normal post-op regime of antibiotic, lotipred, and CMC. I saw that there was a slight delay in the healing of the epithelium, that was around 5 days, and could not remove even up to the 7th day. And that is when I had to remove the BCL post 7 days, that there was a little bit of epithelial deepening in the center. Now, post that, at around 3 weeks, the patient had a vision of 6/9. So I did, and the patient was complaining a slight blurred vision. I started the patient on cyclosporin and then slowly tapered the steroid, that is lotipred, for around 8 weeks. So my question over here is that, as you can see, there's a slight mild haze, and the dry eye status preoperatively was normal. Postoperatively was 10 mm, and there was hardly any change. The refraction, if you see post-operatively, was 0.5 with a 0.5 at 100, which was still, I thought, okay. But as you can see, the anterior segment OCT also shows some haze. My question is, when everything was normal, why was there haze? Still, it's been around more than 6 months now that the patient is still unhappy. And like I told you, acne rosacea in or isotretinoin only in high dosage leads to PRK haze. So I thought that, could it be acne? Could it be delayed wound healing? Could it be high screen time? Also, one more thing that Narayan Netralaya had researched about was mask associated dry eye. That during COVID, a lot of them were using masks. So the hypercapnic air or the CO2 emission from the mask would also lead to ocular discomfort. So could it be that? So I think I'll stop my presentation and just hand it over to our panelists and our mentors to just explain to me where I went wrong and how could I have done better in the second case, and of course to discuss the first case.
If I talk about the epithelial haze, so epithelial haze is something which is very unpredictable. There are people with epithelial growth factor receptor downregulation with the Wnt pathway downregulators, which will always have a very low capacity of epithelial basement membrane regeneration. You know, the epithelial basement membrane regeneration is the key factor for preventing PRK haze. So in people where there is irregular ablation of the stroma, the epithelial regeneration, the basement membrane regeneration is poor. Then per se genetically, as I said, there are certain people who have low epithelial growth factor receptors. So the epithelial regeneration will not occur fast. So there have been patients where with low diopters, just like your case, where PRK has been done, everything has been done properly, mitomycin C, everything. Still, you can have haze. The other thing is acne rosacea is associated with meibomian gland dysfunction. So definitely that would be another pro-inflammatory cause. And whatever stimulates the TGF beta to produce more myofibroblasts, the haze would come in. So definitely, I think preoperatively, these cases of acne rosacea, the isoretinol has to be stopped at least 6 months. The dryness has to be treated properly. And in spite of doing everything, there can be still haze in some patients. The recent advance is losartan eye drops, 0.08%, which attenuates the TGF beta. So the formation of number of myofibroblasts will be much lesser. So losartan eye drops are not available in India and presently, but this could be one of the other choices which could add to the armamentarium of using steroids. And steroid eye drops will not clear up the haze which is produced because of bone marrow cells derived keratocytes, the myofibroblast, sorry. So keratocyte derived myofibroblast, it will regress with steroids, but dendritic cell derived myofibroblast will not respond to steroids.
Yeah, so basically the inflammatory mediators in acne rosacea are the one which are this thing. And
not
also,
only inflammatory, but even genetic factors can play a role. So you may have treated all the inflammation, everything properly, but if you have an epithelial growth factor receptor down regulation, means the number of receptors are much lesser, the regeneration of the basement membrane of the epithelium is much lesser. See, that's why in LASIK you are not getting a haze, because there is a barrier. In PRK, as soon as the epithelial basement membrane is formed, the inflammatory mediators, the TNF alpha and interleukin 1, interleukin 6, they won't percolate down, and TGF beta will not percolate down. So
is there any
that
role of
factor.
cyclosporin? Is there any role of cyclosporin eye drop?
So cyclosporin will work on the MMP9. So that will work on that factor, but haze per se is because of myofibroblast. They secrete extracellular matrix, and the collagen fibers are not organized properly. They're disorganized. So it is a pathological formation of that collagen deposition, which is occurring and giving haze.
Also, I think once you have those hyperemic skin lesions associated, that is not a correct stage to operate. Once those hyperemic lesions on the skin also in those acne patients subside with systemic treatment, that is maybe a correct time to proceed, but there is a straight correlation to them. So when you have a hyperemic skin lesions, perhaps better to avoid mainly the PRK. In your case, the Phakic also was good enough, and it was an unilateral case. A Lasik would have been maybe a slightly better option.
Yes, I do agree with that. Any discussions, Dr. Yogesh sir? Anything you want to add on this, on the haze part? Okay, I think Yogesh sir, your
first case. I think Vaishal sir would know the number of patients that he have already done in the past so many years. If he would have put the data retrospectively in the Accusemics, and if that would have shown a correlation, that perhaps would give the answer to your question.
So basically, it is not that this, see, Dr. Mukesh, the thing is that when you have an abnormal corvis plus an abnormal report on the Accusemics, that's why it was a red flag. And the patient was known and a close friend of Neeraj. So we discussed the case and Neeraj said, I don't want to take any chance.
Himanshu sir, do you have any experience with Accusemics and corvis?
Well, that I'm basically a conflict of interest that I'm part of the team who developed it. So we were the team who developed on that. So yeah, it's as Vaishal said that I don't think I'm claiming that this is something which can be. It's basically it's not a thing which we are trying to claim that this is a new instrument or something. But basically, when you try to collect data from different instrument, naked eye, when you see something which is startlingly abnormal, you may be able to pick up. But when you try to take the combination of certain data which are subtly abnormal and which you may not be able to recognize there on naked eye, and when you keep building up such data, and that's where you sort of create a system where it takes the cue from some small abnormality, which by default, de novo, you may not have paid attention to. So to have such thing, multimodal approach a naked eye, a human brain may not be enough. And that's the reason why you end up using AI. So it's not AI is something, some huge thing, but I'm sure you and me can do it, provided we have enough time to sit and look at every parameter and everything and try to correlate everything and have multivariate analysis of everything, which is not usually possible. The other advantage of AI is that it keeps learning from the cases. So more number of like when we started, we were like very few. So we started with my clinic, then Rohit's clinic, and we were using ourselves. Then the other people we offered. So more number of data we generate and more number of abnormal data we generate where we have ectasia and we start reporting that, that's where it keeps learning from it, and that's where that AI part comes into picture. So that self-learning part of the AI becomes very important, where we have robust database and where it also includes. So in now think about it, if your friend was operated upon, and if we utilize that data, and thankfully if he didn't have any post-op ectasia and something, well, it possibly help us in getting the data more refined, that it would understand. But would you be willing to take such kind of risk? Possibly not. So your question was very right, that will we be actually reducing our
Is it a boon or a bane?
Yeah. So I don't think we should be looking at like that. I surely feel that you should pay attention to your clinical acumen, and if you think about it, you're not convinced, please don't go ahead. There are many times where we may have fallacies in everything. I mean, this is ultimately Accusimics is based on your values from your pentacam, from your Corvus, from your OCT. Now, everything has fallacies. Every instrument has fallacies. Every instrument has test retest variability, repeatability issues. So it does not mean that Accusimics is not something on its own. It's doing something. So please remember that by no means I'm trying to convey that Accusimics you follow, and if it says yes, go ahead and fire. After that, also if it shows safe and you are not convinced, don't go ahead and do it. But if you do it, at least make sure you collect the data so that it can help you in future for collating the data in total, and especially more reason if by God forbid if you end up in ectasia, make sure you convey it to us so that we can include it in the database, and hence it sort of recognizes that you know what these things. So at long run we will have more and more refined way of doing this thing.
So I think we've had a total of many words of wisdoms from our mentors and our panelists regarding very interesting cases presented by the postgraduates. And I would just hand over the dice to Dr. Sumit sir to just give us a final note of thanks before we wrap up the webinar.
I think
Thank you, Neeraj. That was, yeah. The thank note passes on to our secretary, Dr. Atul sir.
Well, I
Atul
thought
sir,
you are
over
not
to
there. I thought you're not. You can give a talk. Thanks. Sorry. Come on, please.
No, you continue, sir.
Okay. Thank you very much. Once again, we have a very nice.
Atul, just before you start, just two comments I want to make.
Okay,
very nice discussion, very good insight of all the refractive tips and tricks we have got, and two suggestions for the postgraduate from my side. So whenever the question is asked by the examiner, I think most important thing should be told first, and then the rare thing should be told. And second is, as Dr. Mukesh already said, tell the things like immediate complication, immediate post-op complication, then late complication in that phase manner. Or you can tell in anter-segment complication, posterior-segment complication. From cornea, you can go ahead to till retina. So that will be means more rewarding for your as far as evaluation is concerned. So these two things I want to tell to the PGs. And very nice discussion. I also learned a lot. And thank you all the panelists and mentors and everybody who has made this webinar successful. Over to Atul.
Yeah. Thank you, sir, for your valuable tips. We have a nice discussion today. Really a very nice presentation by Dr. Tanaya and Dr. Shreya. Being a postgraduate, presenting a case of a refractive on a phakic IOLs and this pathological myopia with Lasik. This is really creditable because I know in my PG days we are not touched by this topic at all. Thank you so much, Himanshu sir. I like the the patterns you said. Whenever you see in a post-refractive case, the patient is not having good vision, how one should go ahead. It's really helpful to so many practitioners, the young persons, refractive surgeons who are members also, not only PGs. As usual, Dr. Vaishal sir is always on the top, and he had a. I am a very big fan of him. See the way he explains the thing and the way he put forward the make the refractive surgery simpler. Mukesh and Dr. Neeraj sir has moderated the show very nicely. Thank you, Mukesh. And the main person behind all this show, thank you, Sumit. He is the one who is doing taking a lot of efforts for all our PGs. So be there. Again, for the next Thursday, we'll have another good session. Till then, goodbye. Thank you very much.
Thank you.
Before that, I want comments from Dr. Himanshu about our PG program. What are your suggestions? What we should improve?
I think Dr. Atul rightly said, I can't even imagine my level when I was postgraduate. I possibly would have seen one or two keratoconus in my entire, or may have seen it, did not recognize. Yeah. My knowledge was nowhere comparable to any of them. The presentations, the confidence what they have, it's at par with any. I mean, fellowship trained cornea fellows or refractive fellows. Their mentor must be really proud, and I'm sure they'll do so well in their life. I'm really happy with the quality of knowledge, presentation, everything. Super package, amazing. If it was post graduation, well, I don't have words.
Thank you so much. Vardhaman.
Yes, so just done with the immigration. So I just got free, but I had a good listening to everything, all the discussion. I think the discussion was done very well. Excellent job, Neeraj, and to have all the questions, and both Mukesh and Yogesh really channelized all the discussion very well with the postgraduates. Thanks to Dr. Himanshu and also to Dr. Kenia. So first, I would like to also tell that there are two things we are coming up with. Three things, in fact. Number one is that there is going to be a MOS masterclass by the legend next Thursday. That is going to be by our pioneer of refractive surgery in Maharashtra and one of the pioneers in the India. That's going to be on next Thursday, 8 o'clock. That is going to be followed by our webinar on refractive surgery on challenging cases. That is going to be soon after that. And the most important thing for our young ophthalmologists is please make sure that you block and you all attain 4th and 5th of May. We are going to have the second edition of our Young Turks MOS midterm conference. That's the only platform given by State Society in India to have their case presentations. Is going to be completely case-based approach. It is going to be having 2 or 3 credit points, and all the senior panel is going to threadbare all the discussions. So again, we all look forward to all the future things for MOS. Thank you, Dr. Agarwal sir. Thank you, Dr. Atulji, and everybody else. Thank you.
Thank you, Vardhaman, and we wish you a very happy journey and best wishes for your presentations over there.
Thank you. Thank you. The flight is flying, fortunately, so it's fine. Okay. Bye-bye.
Bye. Good night.
Yeah, okay. Bye. Bye. Good night, everybody.
Good night.
Okay. Thank you. Thank you, everyone.
Thank you.